Few seconds.
Bismillah ar-Rahman ar-Rahim. I would like to thank the Dr. Muhammad Al-Amri and the organizing committee for inviting me to this fruitful meeting. My talk today is about diabetic macular edema with vitreoretinal interface abnormality, injection versus surgery. It's unlikely that any single mechanism will address the diabetic macular edema in any given patient. There are different phenotypes and mechanisms of DME with exudation, ischemia, or traction. The presence of RPE, molar cell, and astrocyte in the premacular posterior hyaloid suggesting possible role of the cell infiltration in macular edema. Diffuse macular edema was found with attached, thickened, and taut posterior hyaloid. The risk of developing diffuse macular edema was 3 to 4 folds lower in groups of eyes with complete vitreous detachment. Releasing the traction increased tissue pressure and lower the hydrostatic pressure gradient, reducing water influx from the blood pressure into retina. DME could be secondary to traction by cortical vitreous and epiretinal membrane in the absence of vascular leakage. In the management, the success of intravitreal pharmacology for treatment of the DME represents a significant milestone in the regional design of therapy. This patient, after 4 injections of faricimab, this is the right eye, and this is the left eye. Vitrectomy. I found a few papers about significance of vitrectomy in treatment of diabetic macular edema. There is a non-randomized prospective small case series of 87 eyes with vitreomacular traction and non-standardized method, which include ARM removal with or without island peeling, with laser and steroid injection. After 6 months, vision improved by 10 letters in 38% of patients and worsened in 22%. The side effect includes endophthalmitis, retinal detachment, vitreous hemorrhage, and high intraocular pressure. In conclusion, anti-VEGF is critical in driving DME. Sometimes, mechanical traction affects the competence of retinal vessels. Clinicians must judge how significant is the traction play a role in DME. Take-home message: in clinical practice, often initiate treatment with non-surgical approach and reassesses further step accordingly. I have this patient with this obvious ARM and macular edema. I decided to inject this patient. After 1 injection, the macular edema has been increased and the vision is decreased. But I didn't stop the injection. I convinced the patient. He did the second injection about 3 months, and the macular edema started to decrease. So usually I give the chance of 3 injections before determining the next step, unless there is a significant tractional retinal detachment, and in this way I go to vitrectomy. This is a case of lamellar macular hole secondary to chronic macular edema. So after separating the posterior hyaloid and doing the core vitrectomy, ILM peeling is started. Usually I don't do ILM peeling in macular edema alone, but because this patient has a macular hole, I decided to do ILM peeling after injecting of brilliant blue in this case. And we can see that how much the optic nerve is pale, because this patient has hypertension as well in addition to diabetes, chronic diabetes. completing ILM peeling until the arcade. This case has been done, I think, 20 years back. I did this case in Syria. The patient also was pseudophakic. And also, I decided to do fluid air exchange. I left this case under air only. I didn't use any gas. And this is a dual cannula. This is 27 gauge with on the 23 gauge fluid needle. Usually we don't touch the macular hole itself because it will affect the photoreceptors, and triamcinolone was injected at the end of the surgery. Thank you for your kind attention.
Thank you, Dr. Aziz, for sticking to the time and for this nice presentation. Any questions for Dr. Abdulaziz? I will have a question, Dr. Aziz. I know that you mentioned it depends on the membrane itself, how tight it is, is it an epiretinal membrane or just a tight posterior hyaloid, but you always try injection. But the only indication for surgery here is anteroposterior traction. Do you agree with me? I mean, if there is anteroposterior traction, there is no way to inject this patient.
Sure.
Sure.
I showcase that.
Yes.
It is frankly, this is traction.
It's clear. It's an anteroposterior traction. There is no way. But tangential traction, you have to evaluate the inner retinal layers, the outer retinal layers. Injection still has a role, but repeated injection in these cases, sometimes it's hazardous, ends up with lamellar macular hole. So we have to inject him one by one. This is my regimen. I do injection one by one, PRN. And once I see the membrane is getting more tight, though faricimab these days, there's a lot of literature saying that it does not increase more traction because it has an inflammatory, anti-inflammatory angio2 thing. So again, injection one by one, following the membrane. If there's more traction, you go to surgery. If they are improving, you continue injection. Thank you so much for this message. Thank you.
Thank you.